Our next speaker is Dr. Peter McIntosh from the University of Illinois, and he'll be talking about a case I can't see and my MRI is not normal.
I have no financial disclosures to make. This case is a 47-year-old lady who was referred for progressive, painless vision loss. The right eye went out about 2 weeks ago and the left eye about 4 weeks ago. She then went to an optometrist who couldn't refract her better, and that's who sent her over to me. Her past medical history is unremarkable. Her current medications were fish oil, probiotic, and calcium. Her family history is remarkable for a mother who had similar painless vision loss to the 2200 range at the age of about 58 with a quote-unquote negative workup. And she was evaluated at Bascom Palmer many, many years ago, and so presumably a very thorough workup was done at that time. The social history, she denied smoking or drugs, but she drinks about 2 glasses of wine a day. And she works as a financial advisor. On exam, the right eye sees 20/40 and the left eye is 2200, pinholing to 20/60. Her Ishihara color plates were significantly reduced in both eyes, and there was a left relative afferent pupillary defect. The confrontation visual fields were full in both eyes. The external exam was unremarkable, no ptosis, proptosis. The ocular motility was full and normal in both eyes, and the anterior segment was also normal. The dilated exam in the right eye showed a sharp disc without edema or pallor and a normal macula vessels and periphery. On the left, there was a sharp disc without edema, but there was some subtle temporal pallor and a normal macula vessels and periphery. So this is her Goldmann visual field that is consistent with the confrontation with the full periphery, but there are bilateral central scotomas. So at this point, I'm wondering what the panel is thinking based on this history. There are some important factors there. And do you have any thoughts right now about what might be going on with this lady?
I can start. So this is a bilateral visual loss, asymmetric, with central scotomas on both sides. Relatively normal fundus. So one of the fundi had a bit of atrophy, but no disc edema at the start. And you had this feature which we never hear about, which is a positive family history. We try to get that in patients who have this sort of disorder, but we never get it. So you've got to take that into consideration as to whether this is a genetic problem. But other considerations are inflammatory diseases of the nerves, I suppose nutritional and toxic optic neuropathy as well, although the history is not consistent with that. So that would be my starting point, I think.
Agreed. With respect to nutritional, remember, there's a fair amount of asymmetry here, one eye first and the other, so that makes it also much less likely.
Okay. This is the OCT of the retinal nerve fiber layer that shows bilateral temporal thinning. And now, any comments about the MRI?
So it's a T1 with contrast, and you see, if you can point at the same time, you see the intracranial portion of both optic nerves, which the optic nerves look a little bit, what I would say, juicy. They're just a little bit too large, and there is a faint enhancement. I assume there is enhancement. It's symmetric. And here, it's either, again, the nerves are just a little bit larger than what I would expect. I wouldn't say anything here regarding whether there is definite enhancement or not. If there is, it's very, very subtle, and it's bilateral. It may just be the way this MRI machine acquires MRIs.
Yeah, when you look at this, it looks like there's a very bright signal on both of the optic nerves, but if you compare that to the rest of the brain, it's really not much in the way of hyperintensity.
So I would say if there is enhancement, it's bilateral, symmetric, and it's very, very subtle. But it may be there.
Very good. So I wanted to bring this up because I'm wondering if those MRI changes are changing what you think about what this case might be. At the beginning, there was a strong discussion about this hereditary genetic predisposition, but what do we think about these MRI changes? And let's poll the audience. Does that change what you think this might be? Good.
Wow. Very impressed.
Yeah, you're all right.
I know.
Well, that was fast. How did we get there?
There was another clue on the OCT scan that I think might have been helpful that was a little subtle. But besides the temporal atrophy, do you see how the rest of the nerve fiber layer is somewhat thickened, a little bit above normal? And that's been found in both asymptomatic and symptomatic labors, is that the part of the nerve fiber layer that's not atrophic is often thicker, some people think due to axoplasmic flow stasis, because the mitochondria are important in axoplasmic flow.
Yeah, just very quick clinical comment, because we see all those atypical cases, but optic neuritis, inflammatory optic neuropathy, really, in a vast majority of cases, is associated with pain, okay? People complain of periorbital pain, which is a dull pain that is very unpleasant and worsens with eye movements. And most often, we have that. And when we don't, it's still possible to have an optic neuritis, but it becomes very atypical and very unlikely, and this is when the other causes of optic neuropathy should really be investigated. And so the lack of pain, despite a possible mild bilateral optic nerve enhancement, really makes you want to pursue genetic testing anyway.
I mean, we generally think of the enhancement of the optic nerves as a differentiator between optic neuritis and something like labor. At least in the past, we didn't think labor enhanced at all. And more recently, we've seen cases with this very mild enhancement like this, and also T2 brightness in the chiasm particularly, and sometimes in the optic nerves. Not exactly sure what it means metabolically, but it's a finding that is definitely seen with this, not commonly.
The audience want to know, based on the history, the family history, presentation, do you think an MRI was necessary in this case?
Yes.
Yes.
Why?
Yeah.
Well, you're concerned about other things. You're concerned about whether this is an inflammatory disease of the nerves.
Right. Bilateral visual loss, uncertain diagnosis initially. So notwithstanding the family history, which was a definite driver here for the workup, but I think with that presentation, it's hard not to.
So I just want to point out some of the typical and atypical features here, and maybe we can discuss what we think. So typical for Leber's is this sequential, subacute, painless vision loss, these central scotomas or secocentral scotomas on visual field testing, and the classic maternal family history for this mitochondrially inherited condition. I described that the nerve was mostly normal, but you may also acutely get this circumpapillary telangiectatic microangiopathy and pseudoedema. The things that are atypical, and this is, I think, what we should talk about, are this is a middle-aged woman, and classically in our textbooks we're taught that these are young men, about 90% of the time, and older women who are affected are sometimes a little bit older. What are your thoughts about women being affected by Leber's and the age that they present at? And why are they older?
Okay. It doesn't bother me. Women can be affected by Leber hereditary optic neuropathy, and you need to think about it, and you need to look for it when the clinical presentation is suggestive, okay? Older, I don't know why. I'm not sure we know why. You have to remember when we describe the phenotype of a disease, we are basically doing circular reasoning, okay? If you think that it's only young men, then you're going to order the test only on young men, and then you're only going to find young men. Be open-minded. The youngest is a very young baby, and the oldest, I think, is 86 years old so far. And it is not unusual for me to request genetic testing on a 75-year-old woman who has had typical sequential or bilateral optic neuropathy that is painless. With a normal brain MRI, I will get genetic testing.
Will you get standard genetic testing for these 3 mutations? Or if the 3 mutations come back negative, will you do next-gen sequencing on them?
Yes. The 3 mutations account for not 100%, and so again, when we think that the clinical presentation is typical, we get sequencing of the mitochondrial DNA, and we look for other mutations. Fortunately, it's not necessary very often, and unfortunately, you need to be in the correct setting to be able to access this test.
Right, and that's what we did for this patient, and we found this mutation, 10197, and a G to A mutation. And then I reviewed the literature, and this has been described to cause other mitochondrial complex 1 dysfunction, and so that's how we came to this diagnosis. But of course, the important 3 to remember are the 11778, 14484, and the 3460. And of these, the 14484 is actually the most common to have visual recovery, and our patient had visual recovery. But unfortunately, the 11778 is the most common mutation, and those patients tend not to recover vision. What do we do to treat this lady?
You send her to the low vision clinic, you hold her hand, you spend a lot of time explaining what this is, and you do your best. You tell her to not drink, to avoid toxics, to not smoke, and at this point in the US, that's really all you can do. In some parts of the world, IDB is commercially available. You could prescribe it. In the best situation, if the patient has one of the primary mutations, you include the patient in a clinical trial. There are a few still ongoing. When you have a new mutation that has not been reported before, the patient does not qualify for any existing clinical trial, so you're kind of stuck. What do you do?
Exactly the same. Yep.
I think the idebenone issue is very confusing at this point. There are papers that suggest that if you're on the idebenone long enough, like in a period of years, you may start to get a little bit of improvement, but the short term is not very impressive. And then there have been some studies from Europe that have sort of pushed this farther, and they're marketing very heavily in Europe now because it's available and approved there. And also very expensive.
Just want to bring up one other thing here. When this lady came to me and I made this diagnosis, she then wanted a second opinion. She actually went to Alfredo Sadun, and he recommended estrogen replacement therapy. Do you guys have any thoughts about that?
Well, the group at UCSF here has recently discovered that estrogen has some role in restoring function after optic neuritis, for example, that doesn't have anything to do with the normal estrogen receptors. So estrogen may have a role, but not through the classical pathways we think. But that's still conjecture and experimental at this point.
And there is some growing evidence of a neuroprotective type effect with estrogens. So, but none of this is clinically documented in no studies. It wouldn't modify my recommendations for therapy.
As was pointed out by the audience, that may be one of the reasons why older women might be affected in terms of the estrogen in the postmenopausal state.
One other point I wanted to make, I've had some patients who have been on medicines that previously were not known but have recently been found to affect mitochondrial function. And some of these are psychiatric medications, some are antibiotics, some are even anti-cholesterol agents. Something to keep in mind in terms of additional risk factors that you may not have on your radar screen.
Thank you.
Thank you, Dr. McIntosh.